Hi, this is Lacey from Next Gen Institute of Physical Therapy, and this is the knee. So in reviewing the knee anatomy, we have the tibiofemoral joint and the patellofemoral joint. We have medial and lateral menisci that are found on the tibia and provide greater contact area for the femur while helping to create more of a concavity. They assist with joint gliding, they limit hyperextension, and they give support to the weight-bearing surfaces of the joint. So we have the medial and the lateral menisci. The lateral is more O-shaped, where the medial is more C-shaped. They have thick centers but thinner edges, and the vascular supply is from the periphery. So the peripheral 1/3 is considered the red zone, and it has a better blood supply from the capsular arteries. The middle and central portions have poor blood supply. It is innervated with the pain receptors and joint mechanoreceptors. So there's a sense of joint position then that may be affected with meniscal injury, and this could be associated with a loss of joint stability as well. So we also have the collateral ligaments. The lateral collateral ligament is extracapsular. It provides the primary restraint to varus force. It restrains excessive lateral rotation of the tibia and contributes the most resistance to varus stress at approximately 25 degrees of flexion. The medial collateral ligament has superficial and deep portions. The superficial portion primarily restrains valgus force. It contributes the most resistance to valgus force in 25 degrees of flexion, similar to the lateral collateral ligament. Deep portions include the meniscofemoral and the meniscotibial ligaments. These portions attach to the meniscus and either the femur or the tibia respectively. And these provide meniscal support and likely restrain anterior translation rather than valgus. Then we have the anterior cruciate ligament. This is comprised of an anteromedial bundle and a posterolateral bundle. So the anterior medial bundle is considered to be taut throughout flexion, where the posterolateral bundle is more taut in extended positions. The posterolateral bundle provides the greatest restraint to anterior translation up until 20 degrees of flexion. So the ACL provides approximately 85% of the resistance to anterior translation at 30 degrees of knee flexion and slightly less than that at 90 degrees of flexion. Internal rotation of the tibia is also resisted by the ACL, in particular the anterior medial bundle. The ACL also provides stabilization against hyperextension, and it's a secondary support against varus and valgus stresses. A non-contact mechanism of injury would be deceleration in a position of slight flexion with tibial rotation in either direction. The posterior cruciate ligament has an anterolateral bundle, which comprises 95% of the ligament, and a posteromedial bundle, which is the remaining 5%. The anterolateral bundle is taut in flexion, while the posteromedial is taut in extension. The primary restraint to posterior translation of the tibia on the femur is provided by the posterior cruciate ligament. It provides 95% of the stability between 30 and 90 degrees. Although the PCL checks posterior translation then throughout the knee's range of motion here, its deficiency demonstrates the greatest posterior translation between the 70 and 90 degree flexion range. This is because the secondary structures are more lax in these degrees of flexion. The PCL also provides secondary support to varus and valgus stresses on the knee, similar to the ACL. We also have the patellofemoral joint. On full extension, only the inferior pole of the patella is in contact with the femur. As the knee begins to flex, the patella glides inferiorly. There's increased contact area with increased degrees of flexion. The middle of the patella is in contact around 45 degrees. The superior 1/3 of the patella contacts the femur in 90 degrees. Beyond 90 degrees, the patellar contact moves inferiorly and laterally, where it ties into the odd and lateral facets. Patellofemoral joint forces in typical activity would be walking is considered to have to sustain up to 50% of our body weight, where jogging is 3 to 4 times of our body weight, and sit to stand is 6.7 times our body weight. So as the knee flexion increases, so does the quadricep compressive force into the patellofemoral joint. To review the Q angle, normative range for males is 10 to 15 degrees and for females is 15 to 20 degrees. Greater than 20 degrees is considered a structural abnormality, and it's places the patient at increased risk for excessive lateral patellar forces. So the Q angle, remember, is measured from the ASIS to the midline of the patella straight down to the tibial tuberosity. So when evaluating our knee patients, we need to consider the mechanism of injury and also the Ottawa knee rules. The Ottawa knee rules were developed to determine which patients would need radiographs after an acute knee injury. This was validated in another population and found to be 100% sensitive for identifying fractures. So the rules are in age greater than 55, isolated tenderness of the patella and no other bony tenderness, tenderness at the fibular head, inability to flex the knee to 90 degrees, and the inability to weight bear both immediately after and in the emergency room. So it says a knee x-ray series is not required after an acute knee injury if the patient presents with none of the following findings. So screening tools should be sensitive. This tool was to limit unnecessary x-rays, but also to make sure that they didn't miss any fractures as well. So it was in fact sensitive as a screening tool should be. The University of Pittsburgh advocated the addition to the rule, and that was that patients should receive films if there was blunt trauma or a fall as a mechanism of injury, and either the person is under 12 or over 50 or is unable to walk 4 weight-bearing steps in the emergency room. So this rule was also shown to be 100% sensitive and 79% specific, missing no fractures. So based on this study, it was estimated that the frequency of ordering x-rays could be reduced significantly. So this is a review of some of the special tests of the structures we just discussed. So for the MCL, the initial test may be in the evaluation, the valgus stress test and full extension. If you're looking at greater than 5 millimeters, you want to check the PCL and the ACL. The most specific test, though, for the MCL then would be the valgus stress test at 30 degrees flexion. Stress at 30 degrees flexion that's greater than 10 millimeters, you need to be concerned about the ACL. With the LCL, we're looking at the varus stress at 30 degrees flexion, isolating that LCL. For the PCL, initially we might perform the posterior drawer. The most specific test would be the posterior sag with the quadriceps activation. So when you have them up in the posterior sag position and activate the quadricep, you're showing anterior translation of the tibia. If laxity were to increase with the posterior drawer and external rotation, you need to evaluate the posterolateral corner. For the ACL, initially we have the Lockman test. If you have an empty infield with that, then you need to look further, and pivot shift and arthrometer difference of greater than 3 millimeters side to side indicate an ACL tear. The posterolateral corner, we have the posterior drawer increased at 30 degrees where it's normal at 90, and we can also look at the prone external rotation test, looking at a greater than 10 degree difference from side to side. If the prone external rotation test is increased at 30 but not at 90, is what we're looking for. If it's positive at both, we're checking for the PCL. Remember, the posterolateral corner is comprised of the arcuate ligament, the LCL, the popliteal tendon, and the lateral head of the gastroc. So when looking at meniscal pathology, a meniscal pathology composite score has been devised. It's a combination of looking at 5 different tests or assessments. And those 5 things are the history of catching or locking, joint line tenderness, pain with forced hyperextension, pain with maximal knee flexion, and a pain or audible click with McMurray test. And it's shown that there's a 93.3% positive predictive value when all 5 of these are present. That value goes to 75% when 3 of those are present. With the patellofemoral, we can look at the quadriceps make test, the patellar tilt. We're looking at the history and positive response to patellofemoral taping to support the diagnosis. And this takes a look at the sensitivity and specificity of the several meniscal tests that have been devised. So We have everything from joint line tenderness, McMurray's, Thessaly's. Down at the bottom there, it has the composite score that we just discussed and the different sensitivities and specificities based on the number of findings for your reference. So when evaluating, we also need to be aware of how to assess the patellofemoral joint. Options include seated resisted quadriceps make test, looking for the movie theater sign in the history subjective report, a step down test, the SAGE sign, which looks for laxity, an apprehension test, and also assessing the lateral retinaculum. Functional tests can also be performed. These include the HOP tests that I have listed there for you with their normative data, but also could include stair climbing, the 6-minute walk test, the 5-time sit to stand test, and the timed up and go test as well. So when considering rehabilitation of these structures that we've discussed, we also have to consider the healing rates of these tissues. So this is a nice table here that shows you the average healing rates for tendon, both including tendinitis, which does not take as long as lacerations, which could take up to 6 months. It shows muscle healing after something that's exercise induced, obviously responds within several days. And then you can see the difference there between grade 1, 2, and 3 strains. Same thing with the different grades of ligament involvement. The ligament grafts then are at the far right end with the articular cartilage repairs, and the bone somewhere there in the middle then with the rate of bone. So this table shows the screening guidelines for anterior cruciate ligament injury. So ESLAC and colleagues developed a screening process in an attempt to identify potential copers that might be able to return to short-term high levels of activity without surgical management of an ACL injury. So in order to participate in the screen, it had to be an isolated tear of the ACL with no other involved structures. Furthermore, the patient had to have no knee effusion, the ability to hop on the injured leg without pain, full knee range of motion, and greater than 70% of the involved to uninvolved quadriceps ratio. So after they were qualified for the screening, the tests include the noise HOP tests. Now for these, the author did have the patients wearing a knee brace during the HOP tests. We had the knee outcome survey, and for this, the patient had to have a greater than 80% grade for the survey, the global rating of knee function greater than 60%, and the episodes of giving way greater than 1 episode of giving way. So they were considered a non-candidate if there was a failure of any one of their criteria for the rehabilitation. So then rehab candidates were defined as patients who met all 4 of those criteria. They were then given the opportunity to participate in a 10 treatment perturbation training program. At the end of the training program, the patients had to resume full participation in high-level activity, or those were level 1 and level 2 activities, for 1 year to be identified as a true coper. So looking more specifically now at ACL reconstruction, research shows that the majority of ACL tears require surgery for return to high-level sport. So graft options for the reconstruction include the bone patellar bone graft, the quadrupled hamstring, and the allograft. It's important to know the graft that was utilized so we can address it properly in our plan of care. For instance, there's an increased risk for anterior knee pain and extensor mechanism failure following the bone patellar tendon bone graft. There also may be an increased risk in patella fracture with this procedure. So hamstring grafts may not necessarily decrease the hamstring strength, but they could place the patient at more risk for a hamstring strain. So looking post-operatively, the primary concern when rehabbing the ACL is obviously placing too much stress on the graft. So passive range of motion from 0 to 120 degrees shows no strain on the ACL. That's passive range of motion. The greatest strain on the ACL is shown to occur actively within the last 30 degrees of open chain extension. Weight-bearing exercises may decrease ACL strain compared to the open chain exercises, but they actually may not offer enough load to truly improve quadriceps strength after surgery. Weight-bearing exercises do, however, help to improve proprioception while providing joint stability. The graft is the weakest at 12 weeks post-op, so this is important in making sure that we have adequate quadriceps strength recovered by this time frame to ensure adequate graft protection. Studies show that residual quad weakness and loss of full extension can contribute to decreased function after surgery. It's obviously of utmost importance to restore the quad. The program should be comprehensive, include both weight-bearing and non-weight-bearing activity to address ultimately strength and coordination. Further considerations in ACL management, high-intensity neuromuscular electrical stimulation with strengthening program has been shown in research to be more effective than using exercise alone. Also, a double bundle procedure is becoming more popular. The goal of the double bundle procedure is trying to more closely replicate the true biomechanical properties of the original ACL. This procedure is more difficult to perform, but it's been associated with better knee stability during pivot shift testing after the procedure. Other studies, however, have found the double bundle and single bundle techniques having similar outcomes. No variation does seem to be necessary in rehabilitation, though, from one treatment method to the other. If concomitant injuries were present or repaired at the same time, the progression of rehab can change. So, for instance, if a meniscal repair in addition to the ACL reconstruction was done, it would limit the amount of weight-bearing flexion in the first several weeks. If a chondroplasty on a weight-bearing surface was done, it may restrict the weight-bearing in general for several weeks. So both of those instances would allow adequate healing for the concomitant injury rather than addressing the ACL primarily. We know that prolonged periods of non-weight bearing aren't good for the quads or recovery, so sometimes we need to compromise. This may include using different bracing strategies to try to unload the healing tissue, but still allow some form of early weight bearing as well. So the MCL injury can still follow ACL reconstruction guidelines because that's adequate enough to protect the healing tissue. If a combined ACL and PCL reconstruction are performed, in this instance you need to follow PCL guidelines. Stabilization following the PCL generally has a poorer prognosis. Other considerations include individuals that are skeletally immature. The ACL injury is becoming more common in this population. Treatment in this population is still controversial as traditional surgical approaches are contraindicated. This is due to the open growth plates. Studies have shown that a non-operative approach was associated actually though with higher clinical instability. Furthermore, it has been shown that early operative treatment for ACL injuries in this population was better for the patients to return to sports. Avulsions may be allowed a time to heal in a non-operative fashion using just immobilization first. It's also found that a non-operative approach is unsuccessful in an ACL insufficiency in this population. So despite this contradicting evidence, it seems that surgical management is still usually deferred. And what they do is they treat non-operatively, and then when the patient becomes skeletally mature, they can have the decision again to have the procedure done. This, however, could be months or even years after, depending on the patient's age and skeletal maturity. So treatment would be similar to that of a non-operative program. You need to focus on protecting the other structures, so the instability or lack of motor control would not lead to other tissue damage. So if surgery is performed in this population, maybe because waiting is not an option, there are 3 categories for modern operative techniques. There's the extraphyseal construction, and this is a physeal sparing technique that uses the iliotibial band as an autograft. It's passed through the lateral femur and fixed anteriorly on the tibia. There's the transphyseal reconstruction. This is a partial sparing technique. Either the tibia or the femoral physis is spared, and it's coupled with the transphyseal fixation on the opposite side. And then there's the all epiphyseal reconstruction, and this is an intra-articular technique using the four-strand hamstring autograft, and it avoids fixation across the tibial and femoral physis. The rehab approach is similar to traditional surgical techniques for the ACL. Now we're going to take a look at rehab considerations for the PCL. So most PCL tears are partial and can be treated non-operatively. Few actually will end up developing functional instability. So grade 1 and 2 PCL tears recover quickly with usually a goal to return to sport within 4 weeks. Grade 3s are going to recover a bit slower. They might actually be mobilized in extension for the first 2 to 4 weeks. Knee flexion of greater than 70 degrees and hamstring exercises are avoided. Again, this is that posterior translation or stress that we're avoiding. These patients can usually return to sport about 3 months. A literature review found that PCL injuries treated non-operatively returned to activity at a similar level that they were prior to the injury. With PCL reconstruction, we know that increased posterior translation is increased risk for concomitant injuries. These injuries could be meniscal, they could be capsule related, or they could affect the posterolateral corner or even other ligaments. So there's conflicting evidence on the best surgical technique to limit the amount of translation after the surgery. An Achilles tendon allograft is generally used. They try to attempt to replicate the anterolateral bundle, as this comprises the majority of the ligament. Laxity with the procedure is typically reduced by 1 grade level, but it actually commonly returns during the rehabilitation program. So rehab focuses on a slow progression of range of motion, particularly with looking at flexion. Post-operatively in the PCL, the graft is typically tensioned, again, between 70 and 90 degrees. So we're limited beyond that range for the first 4 weeks, up to the first 4 weeks. We want to limit resisted knee flexion. So we're trying to minimize the amount of posterior shear force and loading in the PCL for up to 8 weeks. We really need to be cautious until adequate healing occurs before we go crazy with any resisted knee flexion, and we're looking at a closer to 4-month range there. PCL stress can occur during open chain resisted knee extension as well. This has been found between 140 degrees. It seems to be the greatest between 80 and 95 degrees. It is, however, lower between 60 and 0 degrees, and so that's kind of the range that we keep them in. We also have the posterolateral corner injury. This is usually associated with concomitant injury to the PCL. It's rarely found in isolation. The mechanism of injury is typically a posterolateral force to an anterior medial tibia, or hyperextension, and or severe tibial external rotation when the knee is partially flexed. Patients may feel a sense of instability with cutting and pivoting. Post-op restrictions for a posterolateral corner include non-weight bearing for the first 6 weeks while the patient's in an immobilizer. No isolated hamstring exercise can be performed for 4 months. So now we're looking at the MCL and the LCL. Research actually shows no benefit to surgical versus non-operative management. So these are usually managed conservatively. The LCL is braced in 90 degrees of flexion during weight-bearing activities for up to 6 weeks, depending on the extent of the repair, and this can also be used for non-operative management. It's questionable, however, if the brace is necessary during the rehab process. After the repair, early range of motion is encouraged. So remember, the peripheral third of the meniscus, which we're discussing now, has better vascularity. So a small localized tear to the periphery may respond well to conservative rehabilitation. it may have a better chance of healing. So in this group of patients, we'll probably be performing non-weight-bearing strengthening. We'll be avoiding the squatting and pivoting as well as cutting activities as well. If surgery is indicated, maybe due to locking or giving way, the current trend is to try to save as much of the meniscus as possible. The same considerations of the location of the tear apply. So again, if it's on that periphery in the red zone, we're probably going to get a little bit better healing response. There are no specific precautions for meniscectomy. This is kind of our clinical judgment, and we're monitoring the patient's pain response as well as the inflammation. With the meniscal repair, however, there are some limitations and restrictions. So weight bearing is probably going to be limited and slowly progressed over the first 8 weeks. It's often permitted while locked in extension if the tear was in the red zone. Weight bearing activities beyond 45 degrees are typically avoided. Loaded flexion is also limited beyond 90 degrees for up to 8 weeks. So there are guidelines for the meniscal repairs, and they're all variable, largely dependent on the tear type, the location, and again, the size of the tear. So commonly in the knee, we deal with degenerative arthritis. There are several management strategies for arthritis, including weight loss, exercise, oral anti-inflammatories, steroid injections, modifying the patient's activity level, unloading using bracing techniques, physical therapy, as well as surgical osteotomy. It's important to note that quad weakness is considered the strongest single predictor of functional limitations in patients with osteoarthritis, and pre-op quad strength is predictive of the functional ability in the patient up to 1 year status post total knee. So if you're managing these patients, whether it be pre-operatively or non-operatively, quad strength again is of the utmost importance. So in discussing the osteotomy procedure, the osteotomy redistributes the load bearing away from the joint area. It's essentially a surgically induced fracture, and the bony healing has to be considered as such in rehabilitating these patients. There is a failure rate, however, as high as 25% in this procedure. So a high tibial osteotomy, that's considered with unicompartmental medial compartment degeneration, where the femoral osteotomy is for a unicompartmental on the lateral compartment. This can delay a total knee surgery for up to 10 years, but again, it has that high failure rate. Resistance and full weight bearing is typically not performed in the first 4 weeks. However, full range of motion is allowed immediately. We also have for this condition the unicompartmental knee arthroplasty. This can be performed if other options fail or if degenerative changes continue to be limited to just one compartment. It's easily converted to a total knee later if it's necessary. Selection criteria for this procedure include a maximum of 10 degrees varus or 5 degree valgus deviation, a flexion contracture less than 10 degrees, an intact ACL, the absence of patellofemoral symptoms, and a BMI below 32. And then obviously we have the well-known total knee for severe or advanced degenerative arthritis. So here are a couple pictures of the procedures that we just talked about. To the left you have the osteotomy, and to the right you have the unicompartmental knee. So we also need to discuss articular cartilage injury. This injury can range from acute traumatic injury, which typically happens in the younger population, to more degenerative, which occurs in the older population. When this injury occurs with ligamentous injury, it's imperative to protect the weight-bearing surfaces. We need to again consider possibly joint sparing techniques and bracing techniques to try to keep those unloaded. The ability for the articular cartilage to regenerate has been shown to be more limited with time and age. So we have debridement, chondroplasty, and microfracture procedures for articular injuries. And these are done to stimulate subchondral bone to help facilitate healing. So the purpose is to penetrate the vascular area and create bleeding. This is going to form a fibrin clot, which is going to be rich with stem cells, and this is going to allow for fibrocartilage replacement. So the fibrocartilage replacement does not have all the same properties as the original hyaline cartilage, but it still can provide some form of short-term protection. The weight bearing is only limited for about 3 to 5 days following the debridement or the chondroplasty, with full functional activity return at about 4 weeks. Non-weight bearing is required for at least 2 to 4 weeks after a microfracture procedure, with full weight bearing being delayed to about 8 weeks. And return to full activity, you're looking at least 4 to 6 months for the smaller lesion and up to 8 months for the larger lesions. So we also have a couple other procedures in addition to those just mentioned. We have the osteochondral autograft transplantation. This actually uses bone plugs that are covered in hyaline cartilage that's been harvested from non-weight bearing surfaces of the femoral condyle. These are only used in lesions that are less than 2 centimeters squared. It's actually contraindicated in larger lesions. And then we have the ACI, the autologous chondrocyte implantation. This is more for larger focal lesions, individuals with failed microfracture or osteochondral grafting. It's very expensive and it requires at least a minimum of 2 procedures to be performed. So rehabilitation for these latter 2 procedures it's kind of matched up to correspond with 4 different phases of tissue healing. So during the first phase of tissue healing, or the proliferation phase, the objective would be to avoid stress and protect the healing tissue. The transition phase, this focuses more on increasing range of motion and strength with initial return to function. In the remodeling phase, this focuses more on improving strength, endurance, and function. And finally, in the maturation phase, this is a gradual progress more back to unrestricted activity. Now, in the knee, we also have the patellofemoral joint and associated patellofemoral pain. The name can kind of be deceiving at times in terms of identifying the cause of the pain. So patellofemoral pain is characterized by diffuse pain over the anterior knee. It can be aggravated with increased patellofemoral compressive forces. These forces are found in activities such as squatting, stairs, prolonged sitting, and repetitive activities as well. So the underlying cause is not the same for everyone with patellofemoral pain. Risk factors that increase an individual's chance for having patellofemoral pain are the female sex, having decreased quadriceps flexibility, a hypermobile patella, altered VMO response time, decreased knee extension strength, and diminished quad explosive strength. The diagnosis for patellofemoral pain should really only be considered after ruling out other diagnoses. So this next slide is a clinical classification of patellofemoral pain syndrome. So in the beginning, we're looking at whether or not there's a malalignment or a muscular dysfunction. If there's a malalignment, is it the entire leg or is it more just the patellofemoral joint? If it's the patellofemoral joint, we're looking at whether it's a non-muscular origin or a muscular origin. Now, if we're looking at whether or not it's due to muscular dysfunction, we're looking at strength deficits, neuromuscular dysfunction, as well as flexibility deficits. So obviously for strength, we're looking at the VMO and quadriceps. We're looking at the VMO and vastus lateralis timing dysfunction for a neuromuscular involvement. And with flexibility, obviously, several lower extremity muscles could be involved, but they list here the hamstrings, quadriceps, gastroc, and IT band. Decreased hip abductor and external rotation strength have been shown to be associated with patellofemoral pain. Anything that creates that valgus force at the knee, this could be even a loss support in the foot. There's been studies to determine the benefit of applying a orthotic in the shoe that has conflicting evidence as well. No single one treatment really is the best in this population. Due to the vast array of origins for patellofemoral pain, it's really important in recognizing the specific components that could be causing the patient's symptoms. So if the patient requires surgery for the patellofemoral pain, several procedures can be performed. There's the synovectomy. This could include a smaller plica resection or a larger synovial removal. A lateral retinacular release can be performed, as well as distal and proximal realignment procedures. The patellofemoral alignment techniques can also be performed, and this would be if there was more of an anatomical malalignment. And then we can also see the medial patellofemoral ligament and the VMO advancement. And this is more for chronic subluxation. And we'll often see this procedure done with a lateral retinacular release as well. So we just reviewed the basic anatomy of the knee, as well as common pathologies and appropriate rehab strategies, and also post-op management. So this concludes the review of the knee.